temperature in the emergency department around 2:45 showed that he was still hypotensive to the 70s over 40s. At around 3 a.m., the patient finally got his CAT scan on the way to the MICU from CCT. So the final diagnosis was acute on chronic liver failure secondary to a GI bleed. This is our discussion outline. So first we'll take comments or questions about the case. We'll talk about acute on chronic liver failure, just to define the disease. We'll talk about evidence-based management of acute on chronic liver failure. We'll talk about upper GI bleeds and ultrasound, and then we'll just kind of go through our overview at the end. And so now I will open it up to comments or questions about the case.
You know, you always have to ask why someone who is chronic cirrhosis goes into encephalopathy. And it can be infection, it can be, fluid and electrolytes. But one big thing is GI bleed. They're prone to GI bleed because they have abnormal clotting, they have varices, they have increased incidence of ulcers. So, and when they bleed, they absorb all that urea and stuff and products of blood into their system, and they become more encephalopathic. So without being able to get a good history that he didn't have black stool and he, or didn't vomit up blood, because you can't trust his history, I think you have to, probably should have had the DRE earlier and realize he had a GI bleed earlier. It's just something that you have to look for in these kind of cases.
Any other faculty have comments or questions about the case before I move on? Give it 10 more seconds. Okay. So I'm glad that Dr. G said what he said, because I'm going to talk about why did this happen diagnoses. So there's a group of diseases where we may feel satisfied knowing that we've clinched the diagnosis and it's easy to blame the patient for them. And we often hear things like non-compliance is the cause of their symptoms, whether it's because they're eating salty foods or smoking or drinking or just not taking their medications. This isn't all encompassing, but it includes diseases like acute on chronic liver failure, acute decompensated heart failure, COPD exacerbations, HHS or DKA, and thyroid storm. But it is our job to make sure that we're going beyond blaming the patients and we're asking ourselves, why else could this have happened? Is it because of an infection, or in this case, a GI bleed? Do patients have PEs, or was there a new MI? And so the elephant in the room is that there was a delayed diagnosis of a GI bleed. And so this patient had type C hepatic encephalopathy, which is hepatic encephalopathy in the setting of known liver cirrhosis. And so there is something called the Westhaven criteria that splits the progression of hepatic encephalopathy into either covert or overt with grading involved. The less relevant for us definitions occur with the covert hepatic encephalopathy, with minimal having a lot of nuance and requiring special psychometric testing. Grade 1 usually has that change in sleep-wake cycle that we've heard about and maybe some noticeable cognitive slowing. And then we cross over into the overt. And then that's when we start talking about patients who are lethargic or somnolent and grossly disoriented or comatose. And then alternatively, if you forget these, you can also just describe it based off of their GCS. And so how do all of these features fit together? Well, changes from liver disease can make it easier to develop a GI bleed from any myriad of insults. And GI bleeds can worsen your liver disease. As such, any of the insults that can worsen your liver failure can cause hepatic encephalopathy. And following this, a GI bleed can worsen failure and cause hepatic encephalopathy. So what that means is if we have hepatic encephalopathy or worsening hepatic encephalopathy, we need to be thinking of acute decompensation of liver failure or acute on chronic liver failure, and we need to understand that an upper GI bleed can be the cause of it. So acutely decompensated cirrhosis refers to the development of one or more of the following complications of liver cirrhosis, which may include any or all of these. Again, list is not all encompassing, but it just illustrates what could constitute acute decompensation of a cirrhotic patient. And in our patient, it was the hepatic encephalopathy as well as the GI bleed. There's 3 different organizations that have put forth definitions regarding acute on chronic liver failure, and they're all a little bit different. And I didn't put this graph up here so you can read it, but I just want to point out a few things. Everyone agrees that the patient needs to have some sort of liver disease, and they need to have some sort of precipitating insult, which is usually alcohol or drugs, some sort of infection, trauma, or a variceal bleed. And that needs to lead to some sort of organ failure. And in a lot of cases, this leads to death. It wasn't until 2013 that this was actually recognized as a disease, which is why this is an important study and why we're going to discuss it a little bit. It was a study done by Europeans, and this was the landmark study mostly due to the fact that it was the first to acknowledge that acute on chronic liver failure was a distinct syndrome in and of itself. They classified the patient presentation based off of grade, with grade 3 carrying a 28-day mortality of a little bit more than 75%. And they were often younger, currently drinking, and they often had an infection with SBP and pneumonia being the most frequently identified infections. The patients also tended to have higher white counts and higher levels of CRP, and that likely plays into their proposed pathogenesis, which wasn't really fully understood, but it was thought to be driven by systemic inflammation. And the idea was that if you're younger, then you're able to mount a more robust immune response. And what we can probably take away from this is that we should have a higher clinical concern for younger individuals coming in with complications of liver cirrhosis, as they are the most likely to do poorly. And the most important thing that you can do for these patients is to identify the precipitating event, which in the Western world will most likely be an infection or alcoholic hepatitis. The caveat is also that in about 40% of these patients, there may not be a precipitating etiology discovered for their acute decompensation. But still, it's important that we identify or rule out other causes in the emergency department, because the diagnostic momentum, as with our case, may lead our consultants to the wrong conclusions, as with our patient whereby everyone was kind of on board with the idea of this being a prolonged post-ictal state. And for emphasis, a large number of these patients will have their decompensation caused by an upper GI bleed. So while we're working to try to find if there's a cause for their acute decompensation, we still need to provide them with supportive care. So the most important thing to support in our patient was the hemorrhagic shock. This group looked at patients who came in with any cause of an upper GI bleed and randomized them based off of whether or not they had liver cirrhosis or not. The restrictive group was a goal of 7, and the liberal group was 9. The group found less bleeding in the restrictive group, with 51% of the restrictive group not receiving any blood. And with their subgroup analysis, they found that the mortality was lower in each of the groups, except for the Child-Pugh class C cirrhotics. And that class just delineates patients with decompensated disease. Fortunately for us, we don't really have to relearn anything, as this isn't any different than the other literature in critically ill patients with the TRIC and TRIS trials, which established our transfusion goals of 7. This specific study was important because the TRIC and the TRIS trial excluded patients with active blood loss and liver disease. So when there's evidence of an upper GI bleed in the cirrhotic patients, antibiotics have been shown to decrease bacterial infections, all-cause mortality, bacterial infection mortality, and hospital length of stays, as well as rebleeding events. And so when we give antibiotics, it's mostly to cover gram-negative bacteria. And for the most part, we're going to be choosing ceftriaxone. And I have thrown up here the antibiogram for our emergency department. And while we're looking around for the most common culprits, some reviews said E. coli and some said Klebsiella. But in either case, we can see that as long as you don't have a reason to be suspicious for ESBL, ceftriaxone should be effective in most of the infections. And so to understand octreotide's use in GI bleeds, we have to understand some of the physiology behind a variceal bleed. The cirrhotic liver here creates more resistance to flow from the portal circulation, which ultimately ends up causing dilation of these collaterals. On this graph, the hot pink arrows indicate increased blood flow towards the splanchnic arteries, and those are just the arteries going to our GI organs and our liver, which also shunts blood away from the systemic circulation because the liver isn't going to be breaking down nitrous oxide, carbon monoxide, or prostaglandins as well. And these will preferentially dilate the splanchnic arteries, which is why these arrows are smaller. Octreotide acts here, decreasing the production of the vasodilators, and that leads to the vasoconstriction of these arteries, which decreases pressure through the varices. So this Cochrane meta-analysis showed that octreotide really doesn't save lives, but it does save about a unit of blood per patient. They couldn't find any effect on mortality, need for balloon tamponade, no effects on rates of rebleeds, or the number of patients that failed initial hemostasis. And so I wanted to reorient you to the patient's PT of 25.9 and how it doesn't really matter. The PT is a measure of how quickly the blood clots via the extrinsic pathway and kicks out this value. But the PT and the PTT are only half the equation. They are measures of your body's ability to build a clot, but it doesn't tell you anything about how well it's going to break it down. There's a concept called rebalanced homeostasis in liver disease. So while a broken liver may be producing less of your procoagulant factors, it's also going to be making less of your anticoagulant factors like protein C and protein S. Because this rebalanced homeostasis isn't reflected in our PTT and PT, and an abnormal value doesn't tell us much about anything about their ability to clot, and high PTs or INRs have not been found to predict bleeding after procedures. And oftentimes, being a cirrhotic actually is considered to be a procoagulable state that puts patients at risk for things like PEs or DVTs. And it is for this reason that the Society for Critical Care Medicine recommends the use of TEG to help guide resuscitations. TEG lets us check in on the real-time altered activity of pro and anticoagulant pathways, as well as the strength of the patient's clots. In this study, they looked at two 30-patient groups and split them between INR-guided resuscitations versus TEG, and 100% of the INR patients were transfused with FFP, platelets, or both, while only 15% of the TEG group required transfusions without any change in increased risk of bleeding or death. So if you stick with your standard defend the MAB to greater than 65 ethos, you really wouldn't be deviating from guideline recommendations. The Society for Critical Care Medicine bases these recommendations off their sepsis recommendations, but it's a very meh recommendation, as they have a remark that the MAP goal might be higher or lower depending on how the patient looks. Now, because most of us will likely go to the Internet Book of Critical Care, I did want to mention that they support a goal of 85 millimeters of mercury if you're concerned about hepatorenal syndrome, but we won't be able to make this official diagnosis in the emergency department because it requires 2 days of albumin administration and a withdrawal of diuretics. So it wouldn't necessarily be wrong to shoot for a higher MAP when we see them if they have an AKI, but ultimately the data surrounding MAP goals in this population is trash. When it comes to fluid resuscitation in these patients, the general recommendation from the Society for Critical Care Medicine is use albumin, especially if the patient's albumin is less than 3. This is in part because of research showing that albumin infusions after large volume paracentesis seem to help post-paracentesis circulatory dysfunction. So the thought is maybe albumin is helping in some other yet to be discovered ways, like helping with immune regulation or endothelial regulation or dysfunction. The Albios study tried to determine if resuscitation with albumin and a resuscitation goal of albumin greater than 3 led to improved mortality versus crystalloids alone. And they found there really wasn't a benefit except for a slight decrease in the mortality of patients who were in septic shock at the onset of their presentation. The Attire trial took a bunch of patients with any reason to have acute decompensation of liver cirrhosis and didn't find a difference between targeting an albumin of greater than 3 or less than 3, but they paid little attention to the hemodynamics of the patient. Ultimately, there isn't much in the way of research to say that we should resuscitate with albumin, except for the things it's actually indicated for. So SBP, large volume paracentesis, or hepatorenal syndrome. But the Society for Critical Care Medicine recommends it because of pathophysiological rationale. So the recommendations for vasopressors are nearly identical to sepsis. So if you remember how to treat hypotension and sepsis, you're most of the way there with some caveats. So we'll be discussing the surviving ACLF recommendations. Norepinephrine is still first line. However, this is extrapolated from the Society for Critical Care Medicine's recommendations in septic shock. As a second line agent, they recommend vasopressin over epinephrine because of the increase in lactate associated with epinephrine. They don't think that it's harmful. They just worry that because of the decreased lactate clearance in liver failure, you may not be able to use the lactate to guide your resuscitation. There was one small study that showed vasopressin analog was as effective as norepinephrine. But I think if we already have a schema to start norepi first and it's in our code cards, it's best just to start with norepinephrine. They don't say not to use norepinephrine. However, you may be better served starting hydrocortisone over a third pressor. And if you're on a second pressor, you might want to include it anyways. Cirrhotic patients are often found to have corticosteroid insufficiency. And these studies indicated that a patient like ours has at least a 30% chance of having adrenal insufficiency. And these indicated studies where there was more than a 50% prevalence of adrenal insufficiency. And even so, the data supporting its use is relatively absent, and it's been shown to help decrease need for vasopressors, but with higher rates of adverse events. And the Arabi trial down here actually ended early because of its futility and the adverse event rate associated with the corticosteroid use. Ultimately, there isn't a lot of great evidence in this population, and the Society of Critical Care Medicine is basing their recommendations off of sepsis data and the studies that show that we have a lot of adrenal insufficiency in patients with liver disease. So for the intubation, for the induction, we spoke earlier about how our patient has a 30 to 50% chance of having adrenal insufficiency simply by having acute on chronic liver failure. So etomidate would be a poor choice in these patients. Otherwise, again, there isn't great trial data or any formal recommendations for specific induction or paralytic agents for these patients. But in general, the induction agents that we use, like ketamine or propofol or etomidate or benzodiazepines, are metabolized by the liver and will have prolonged half-lives in the setting of liver dysfunction. If we're looking for a paralytic available at King's that is unaffected by liver metabolism, cistatocurium or Nimbex, which is much easier to say, is probably a safer choice over rocuronium. Succinylcholine will have the shortest duration of action, but as with our patient, it would be contraindicated in hyperkalemia. And so upwards of 90% of the cases of hepatic encephalopathy will be successfully treated via treatment of the precipitating factor. So I'm just going to emphasize again, that's important to find the cause of acute decompensation. As far as the medications are concerned, lactulose is recommended as the first-line agent. But that being said, polyethylene glycol has been shown to improve hepatic encephalopathy more quickly than lactulose. And together, lactulose and polyethylene glycol have been shown to decrease the hospital length of stay in women. Rifaximin is usually added next and has a good amount of support behind its use, both in terms of improvements in length of stay and mortality. It improves the outcomes of patients when combined with lactulose. And so lastly, I wanted to address identification of the upper GI bleed on ultrasound. And so admittedly, when I saw him, I walked over very confidently prior to the POCUS with a paracentesis kit. And as we were doing the ultrasound, I said, well, that looks weird. I don't think it's a spleen. We don't have any free fluid, but there's no ascites and the FAST is negative. And so what is interesting about this case, aside from the not having done the DRE, is that while we had a negative FAST, we could have made the diagnosis from the get-go with the information that we had. And so this, again, was this is probably closer akin to what we saw on the initial ultrasound. And so the video shows a full stomach. It showed heterogeneous material with a distended stomach, with the active movement likely representing active extravasation of blood into his abdomen, both from the esophageal and the gastric varices they eventually found. And so this was a case report that was written that detailed a near identical case whereby a patient with cirrhosis and alcohol abuse was brought in for being poorly responsive, and a FAST exam revealed a distended stomach full of heterogeneous material, as with our patient. And that patient had an OG tube placed, and after blood was suctioned, the patient was initiated on treatment for a variceal bleed, and ultimately he received 14 units of PRVCs with an EGD later confirming active variceal bleeding. And so I'll go through his ICU course. And so everything after this is what happened after he moved upstairs. At around 5:30 in the morning, the read for the CAT scan was communicated to the primary team that showed interval progression of liver disease with cirrhosis and portal hypertension. It showed a distended stomach with hyperattenuating components suspicious for hemorrhage, suggestion of lesser curvature and distal esophageal varices, hyperattenuating fluid throughout the colon, suspicious for hemorrhage, a globally distended bowel without transition point consistent with ileus. At around 8:30, the MICU and the GI placed a Blakemore, and at this point an EGD was attempted, but they couldn't see anything due to the active bleeding. Sometime between 8:30 and 12:30, both IR and Gen Surg were consulted. IR requested that they try the EGD one more time, and if it fails, they'll do a TIPS. And at this point, the patient had received about 11 units of blood. At 12:30, a second EGD is performed, and blood was found throughout the esophagus and stomach. Large varices were seen in the distal esophagus, and bleeding persisted despite banding, so the team pushed forward with the TIPS. And at around 2 p.m., the patient underwent his TIPS. On hospital day 2, palliative was consulted, and the patient was made full code. He also started to have fevers with a temperature max of 103.1, and he was started on vancomycin. GI noted that he had some bleeding in the anterior nares, and it was pooling in the posterior oropharynx, so ENT was consulted, and they noted some anterior nose bleeding for which the patient had bilateral nares packed. On day 4, the neuro ICU was consulted for facial twitching, and EEG was performed, and it showed hepatic encephalopathy, and he continues to be febrile. On day 5, the patient developed a new AKI, thought to be secondary to hepatorenal syndrome. Albumin was started. The neuro ICU had an epileptologist look at the EEG, who reported that they did in fact see seizures, so Keppra was started. On day 7, his fevers continued, and his sputum culture was positive for ESBL E. coli, so meropenem was started. On day 8, nephrology was consulted for worsening creatinine, as it was now 2.1, up from 1.2 at presentation, and they believed it was due to a combination of ischemic ATN, superimposed by contrast-induced nephropathy, vancomycin-induced nephropathy, and bile cast nephropathy. A CT head was repeated because the patient had a RAS of -4 off of sedation, and it showed diffuse cerebral edema consistent with an anoxic brain injury. On day 9, his hemoglobin again dropped from 7.6 to 5.5, and 2 liters of blood was suctioned from the NG tube. The TIPS was reassessed for patency because they were worried that it had failed. It was found to be patent, and the MTB was reactivated. And at 9 p.m. that night, the family changed the patient's goals of care, and he was terminally extubated. And of note, throughout the duration of his stay, he was on PPIs, twice daily, octreotide, levofed, and vasopressin. So in summary, just remember that being young is a risk factor for death. Remember, to be a detective, you need to search intently for the cause of acute on chronic liver failure. If you forget nuance, the data sucks anyways, so you can treat it like sepsis. Remember to ignore your INRs and PTs, and if we have the ability to get a TEG, get a TEG. And if you have a distended belly without ascites, check the stomach. And these are my resources. That's it.